Welcome to The Explainer. Today we're diving deep into a pathogen profile on amoebiasis. This disease, caused by the protozoan parasite Entamoeba histolytica, is a master of disguise. We're going to unpack its pathophysiology, some of the real challenges in diagnosis, and of course the strategies for managing it. So here's our roadmap. We'll start with what I like to call the two-faced nature of this parasite. Then we'll look at how we unmask the culprit with diagnostics. After that, we'll explore why it's such a uniquely resistant foe, what's in our therapeutic arsenal, how to break the chain of infection, and finally, what happens when the infection really escalates. All right, let's jump into our first section. Amoebiasis presents with this incredibly broad clinical spectrum. And it's really this duality, this ability to be two things at once, that makes it such a significant challenge for clinicians. So at its core, amoebiasis is an infection by Entamoeba histolytica, but the outcome is just wildly variable. You can have someone who is an asymptomatic carrier, just shedding cysts, completely unaware, or you can have severe invasive disease caused by its motile trophozoite stage. You know, that transition from a quiet commensal to an aggressive, tissue-destroying pathogen is really the central mystery of this parasite. The disease really shows up in two main ways. First, there's intestinal amoebiasis, what we call amoebic dysentery. This is when the trophozoids invade the colon, causing cramps and that classic bloody mucoid diarrhea. But the second form, extra-intestinal disease, is far more sinister. This is when the parasite breaks out of the gut, travels through the bloodstream, and sets up shop elsewhere. Most often, the liver. It creates these pockets of liquefied tissue forming a hepatic abscess. To make this concrete, let's imagine a case. A 45-year-old traveler comes back from an endemic region. He's got a 2-week history of right upper quadrant pain and a fever, but here's the key: no significant diarrhea. This presentation screams invasive process, not classic dysentery. And this brings us to a really compelling point. Even in places where this disease isn't common, the risk of it spreading within a household is very real. It just drives home the point that you can't let your guard down. Vigilance is absolutely key, no matter where you are. So this leads us right into diagnostics. With such different ways this disease can present, how on earth do we pinpoint the pathogen? Well, the strategy has to be just as multifaceted.
The diagnostic approach really depends on the clinical picture. If you're suspecting intestinal disease, that bloody diarrhea, you're going to be looking at stool samples. You're hunting for cysts or those hemophagous trophozoites under the microscope, or using PCR to find parasite DNA. But for extra-intestinal disease, like with our patient, the parasite might not even be in the stool anymore, so you have to shift gears. The focus becomes serology, looking for the body's antibody response paired with imaging, like an ultrasound or CT of the liver. In our patient's case, his stool was negative, but his serology came back positive, and a CT scan lit up a big solitary abscess right in his liver.
You know, the source included this little bit of humor, but it actually gets at something important in the parasite's name, Entamoeba histolytica. Histo for tissue, and lytica for its ability to lyse, or just completely destroy that tissue. That's its signature move. That's what causes the abscesses we've been talking about. Let's move on to the unique nature of this pathogen. It's so important to understand this because it explains why our usual models for antimicrobial testing just don't apply here. This is the fundamental point. E. histolytica is a protozoan parasite. It's a eukaryote like us, not a prokaryotic bacterium or a fungus. And that biological distinction changes everything when it comes to how we approach it clinically. So because it's a protozoan, the standard antimicrobial susceptibility testing that we rely on for bacteria is basically useless. It's incredibly difficult to culture in a lab in a way that's standardized for clinical work. What this means is that treatment has to be empirical. We have to rely on established clinical protocols and our knowledge of how specific drugs attack the parasite's unique biology. This brings us directly to the therapeutic arsenal. If we can't get susceptibility data, what is the standard of care for treating amoebiasis? The standard protocol is a very elegant two-phase approach. Phase 1 uses a tissue-active agent, metronidazole, to wipe out the invasive trophozoites. So for our patient with that liver abscess, he'd be getting this intravenously.
But that's not enough. You have to follow it up with a 10-day course of a luminal agent, like cleoquinol. This second drug is absolutely crucial because it kills the cyst hanging out in the intestine, cysts that metronidazole doesn't touch. Skip this step and you risk a relapse and continued transmission.
Now, there is one major critical exception to this protocol: pregnancy. Cleoquinol is contraindicated. In these cases, the go-to luminal agent is paramycin. It's an aminoglycoside that isn't absorbed by the body, but its use requires very careful consideration and formal documentation. It's a real balancing act between maternal health and any potential risk.
And a quick but vital note on kids. Children can get severe amoebiasis, but the dosing has to be precisely calculated based on their weight and age. This isn't something you guess. It requires consulting specialized pediatric formularies and, frankly, getting an infectious disease specialist involved. Okay, we've talked about treating the patient in front of you, but what about the bigger picture? Section 5 is all about the public health side of things. How do we break the chain of transmission?
Prevention really all comes down to one thing: interrupting the fecal-oral route. The pillars are what you might expect: meticulous hand hygiene, safe food prep, and making sure drinking water is safe. But a really critical step is contact tracing. Investigating household members of a confirmed case is essential to stop that secondary spread in its tracks. And this all connects to a larger public health mission. Reporting these cases isn't just bureaucratic red tape. It is absolutely essential for surveillance, for identifying potential outbreaks, and for protecting the community as a whole.
Finally, our last section. What happens when treatment fails or the diagnosis is delayed? What are the really severe consequences when this infection escalates?
Well, the complications tend to follow those two different paths we've been talking about. Chronic intestinal disease can lead to malabsorption, serious weight loss, and even growth retardation in kids. But the complications from invasive disease are much more dramatic and life-threatening. If our patient had waited to get care, that liver abscess could have ruptured into his abdomen, causing peritonitis, a surgical emergency. The parasite can spread systemically. In these scenarios, the mortality rate is terrifyingly high. So let's just quickly recap the absolute must-know points. First, remember amoebiasis has two faces: intestinal dysentery or invasive abscesses. Second, your diagnostic strategy has to match the presentation: stool analysis versus serology and imaging. Third, treatment is a 1-2 punch: a tissue agent like metronidazole followed by a luminal agent. And finally, prevention is all about hygiene and sanitation. I'll leave you with this final thought. Amoebiasis is an ancient disease. It's been with us for millennia. But in our hyper-connected world of global travel and changing climates, are we giving this ancient enemy new opportunities to thrive? That's a critical question for global health in the 21st century. Thank you for joining this explainer.